Hey everybody, welcome back to the ECG channel. My name is Reid, and don't forget that you can download the PDF in the description below. It's linked so that you can follow along with this ECG, share it with your friends, save it for later, do whatever you want to do. And don't forget, if you enjoy the content, to like this video and subscribe to the channel and comment whatever you want to say. So, all right, let's jump into it. So first thing we're going to do is we're going to look at the forest, and the trees of the forest, remember, are our QRS complexes. Start here at lead 2. Notice I've got a wide complex rhythm that seems to be pretty regular, right? It goes all the way through, seems to be kind of right on par. And then I've got this funky, bizarre beat there. So I've got, seems to be normal until right at the end I get this kind of change in morphology. It remains to be wide, but very different morphology, okay? I notice, right off the bat, when I look at this wide complex rhythm, I'm like, what is this? What is it so regular? And I look at it, and I look and I see right in front of each QRS, what do I see? I see these, I'll do it in green, pacing spikes, right? So I see pacing spikes. And so when you see a pacing spike, you know this person's got a pacemaker, of course, right? And that's the electrical shock that it's giving to the myocardium. And when you see a QRS that occurs just after that pacing spike, you know that this is pacing in the ventricles. So this is a ventricular pacing spike, right? Doesn't mean that this person doesn't have a dual chamber pacemaker. That just means that right now they're being paced in their ventricles, all right? And you can see that the rate of pacing is very, very, very regular. It is very regular. You can see the rate is, if I start here, you see it's 300, 150, 100, 75, just under 75, maybe like 73 beats per minute or so. Right? You could do it exactly if you wanted to, but I'd say generally you can see it's ticking away at that exact same rate, right? And so, well, is there a P wave? Is this an atrial sensed ventricular paced rhythm? What is going on? And so, well, I see that I have not really any P waves that I can really see with my own eyes that really look distinct like a sinus P wave, but I see, if I look in V1, I see this baseline fibrillatory pattern. So I know that in the atria that we have kind of this fibrillation, we've got atrial fibrillation, right? So this person's got atrial fibrillation, and they're being paced in the ventricles. Well, why does this matter? What does this tell us about a little bit about this physiology? Well, we know that AFib is usually characterized by fibrillatory waves kind of sporadically going throughout these reentry circuits in the atria. And we know that the AV node is a bystander, and the AV node will have these kind of fibrillatory reentry patterns bump into it all the time. And so whenever the AV node's ready, it'll take that signal and it'll send it down into the ventricles, right? But obviously, if you could imagine, if somebody has AV node block, right, their AV node is, less than optimal in the way that it performs, then any time that we have these fibrillatory waves bump into the AV node, it's going to get blocked. And so these people will likely have a pacemaker where you have pacing wires coming off the pacemaker box, which is just under your skin, that go into the ventricles. And oftentimes nowadays, the standard of care is to have a dual chamber pacemaker, right? Obviously, my atrial pacing lead isn't going to be able to pace because we're in AFib, right? The atria is being activated all the time by these reentry circuits. And so what's happening is this pacemaker wire that's down here in the ventricles, it is what we call sensing, right? And it senses and it waits. It waits. And if a certain amount of time passes, and that's pre-programmed, and if a certain amount of time passes and we don't get a QRS that is conducted down, then we get a pacing spike, right? We pace the ventricles, which causes our wide complex QRS. So that's what we're seeing here. We're seeing this person's AV node is not working fast enough, and so every about 73 beats per minute or so, we're getting another pacing spike in the setting of atrial fibrillation. So that's what we're seeing, right? We see that the QRS morphology is wide complex and it's negative in the inferior leads. That tells me it's going away from the inferior leads, which makes sense, right? The pacing wire is usually sitting low in the right ventricle. And so whenever it paces, it sends signal away, right, from bottom to top. So that would be negative in my inferior leads. So that really makes a lot of sense physiologically, right? It's even upright in lead 1, which tells me it's going more from right to left, which makes even more sense if it's sitting in the right ventricle. I just love the ECG. So that's what we've got here. And then now we've got to figure out, well, is everything okay? Can we say that there's not any ST or T wave changes? Well, we know in the setting of a left bundle branch block or a ventricularly paced rhythm, you can use Scarbosa criteria to evaluate if the ST or T waves in the setting of a ventricular paced rhythm are appropriately strained, because we can have variations in the ST and T wave in these settings. And so we want to make sure that there aren't any extra changes, which I don't see any here, and you can look up that criteria. It's pretty simple once you read it. So now we're just, left with this wide, complex beat. And so it becomes early, so it's a premature beat. And I want to make sure that this isn't a premature beat where the AV node decided to let a signal down quick, right? Because we know that sometimes if the AV node lets a signal down too fast, you can get aberrancy, right? We would call that would be like Ashman's phenomenon. It's a pretty cool phenomenon, right? It's essentially like a functional right bundle branch block. So we look for a right bundle branch block morphology. I don't see it, right? If I look in V1, I don't see a right bundle branch block morphology. I see a wide complex beat that's early. This is very likely to be a premature ventricular contraction, right? So what do we have? Let's put this all together. Well, we've got AFib with ventricular pacing that's occurring at roughly 73 beats per minute with a single premature ventricular contraction, right? This is not Ashman. So if you want to learn about Ashman, if you want to learn about it, I have a playlist that's all things ECG. If you go to the page, I kind of have it in linear order so that if you're a beginner ECG kind of learner, you can watch it from the first video all the way down, and it should be in an order that is better for your kind of progression in your learning, right? But here we've got a nice PVC. Hope this helps you. If you have any questions, put them down in the comments, and if not, thank you so much for watching, and have a great rest of your day. See you on the next ECG video.